What do I want to do? What do I want to do? There we go. Okay, now I want to get the embed code. Okay. Uh, Phil?
Need to convert. Yours doesn't have a converter. No one's using this one. Hold this out.
Oh, okay.
Yeah.
The MacBook. Limited USB ports.
Mm-hmm. This is yours, right? Which
Yeah.
one is it? You just drag it to this one.
Phil, can you hear me? Can you hear me?
Large.
Can anybody hear me?
Hold on. Oh, wait. Do you have any videos or
Yeah.
something?
Yeah. We tested it yesterday, right?
It worked?
Yeah. We can maybe.
We can do it again.
Yeah.
Does anybody really care?
Just ask the professor.
Let me check the thing before we test it out.
Yeah.
See if it works. Yours?
Oh, great, you can hear me. Okay, after the speakers finish,
Prominent faculty. Like a small fish.
the screen just goes to a big icon of the Cornell, and we can't see the people. It just gets minimized, and all we see is the banner for Wild Cornell while these people are talking. If we could please leave the camera on the auditorium after the presentation when they're answering questions. Okay, can we do that?
Yeah.
I know you can hear me.
Okay, yeah.
Works.
It looks like it works.
Cool.
All right.
See what happens after the person finishes.
In video.
The banner of Wild is put on, and it takes up the whole screen, and we can hear people talking in the background, asking questions. But I'd like the screen to stay on the auditorium. Okay? Can we do that?
I just want to know which one of these do you know were done already? Are these just cases? Or
I'm not sure which one was done yet for these. I don't know if we put them there.
Okay, I'm gonna dump these all into the folder.
Well, this is the one that he has to do later after Dr. Hartle's talk.
Okay, so this is for today.
Yeah.
So I'll make a new folder for today. Day 2.
It's gonna be MISS day 2.
Yeah, day 2. This
Okay.
so I think these were done already. I think that one was.
Qureshi's been done.
So I'll dump that in there. And he uses on the laptop anyway, so.
Hey, Roger, how you doing? Thank you for inviting me.
I'll leave these out.
Yeah, I'm not
'cause
sure about
I'm not
those,
really
sorry.
sure about them. I mean, this,
Let's
well,
see, yesterday.
I could just read what it's
Actually, highlights is probably done. Unless that was done yesterday.
Okay, and it's not gonna be used today, you know?
So I mean, those are probably all done because they're all before.
Oh, this was someone kept playing.
Oh, the
this
poster.
Do you want to keep this out?
Yeah, can we keep this?
Yeah.
And then, who is this? Burke?
That was
I think
done.
Burke did it.
Because, usually they have this DNA every year.
That's
Video.
the video, yeah.
Maybe I want your brain and things, Michael, you write all this.
Fair enough, that's Burke. So let's-
Wednesday,
Okay.
I think it's May 16th, Wednesday, I'm going to go
All right. So
Right.
Dr. Uribe is going to use his own for the first talk. And I'm guessing Dr. Hartle's going to use ours.
Mhm.
Did he? Because he had a whole folder yesterday. So
Dr. Hartle,
do you know if he's using any of these for today?
60s is done, over the top is done, housekeeping is done. I don't think he's using those.
Okay.
And ask him.
Hi. Oh, it's you. Sorry.
Yes,
Okay,
John
Stuart.
was asking a question. He
Okay.
said he's seeing just a banner that takes up the whole screen and wants to see the camera.
Yeah. Hey, Phil, can you hear me?
Also, he says, yeah, well, he says it right here. Yes, I have a request to have the camera stay on the auditorium for the questions. Okay. All the internet sees is a large block Cornell Medicine Act. I assume it's this. Doesn't see camera.
I mean, that's going to be really. I'll go chat with him in the back.
Just let him know this is Phil.
Yeah. Hey, Phil, are you on now?
You're kidding. What happened when Mr. Lancaster signed and did he say or no? He's another one that is. I talked to him the other day. I said, that's his fine, when you try hard. I hooked him up with a guy I worked with. Way of keeping the hospital. That a little bit better. Okay, man. Thank you. Yeah. AO work, good.
It's okay. I'm still involved. I wasn't in Davos this year, But we're meeting again next February. Make some plans for that curriculum. Hopefully it'll go strong. Yeah, I made yeah, just this morning. Made changes this morning.
On your previous version.
Yeah, the navigation.
On the previous version, right? Because we didn't.
Yeah, no, I didn't. I took your figure, but I put it into my top.
So you have the latest version, Peter?
Yeah, yeah. Thanks.
Roger, May 13.
Okay, let me see.
See you. Looking good? Already hooked it up and it seems to work. Perfect. Yeah, thank you.
Juan, do you know Shakash?
Yeah.
Yeah,
We met a few times. Yeah.
yeah, he's a superstar. You know, when he shows up, I always get nervous. I always make sure everything's okay.
That's the
He's
way.
very, you know, he picks up on everything, every little detail.
That's the good fellows, my friend. They really are on the top of the game.
Oh, he cancels it. He's overcommitted. Talk is fine, but the debate is kind of always debate is invite someone to debate. It's a bigger thing, you know.
Exactly. Guy when I was getting bad teacher. So he's gonna say next time I should show up there. I was not there. Trying to find all these conflicts on the online.
What?
Trying to find all this money that he's getting from those.
Oh, yeah? Oh, yeah, of course, yeah, for you, important for you as well, as the person who's, yeah. Real about, you know, where people use robots.
Morning. The internet we use, I'm not sure. Sertaj, so the internet connection is Cornell Guest, right? Cornell Guest.
WCNCJ.
Yeah. Oh, you want to see here? You go here.
One, yeah, that one. So
WCMC.
so no, but for the rest, I think it's WCMC guest because this is tagged computer.
Yeah.
We can't connect to Wild Cornell Medicine, but other people should.
A
connect to the-
WCMC guest.
Yeah.
That's one too many.
Juan, do we have you talk?
Yeah, ready?
Great. I'll have you set it up. Start a few minutes late. Yeah. All right, welcome. Good morning, everyone. I hope everybody had an enjoyable evening and got some rest. It's going to be less cold today, so it's going to be a little bit more pleasant. But then again, there's no reason to leave the room anyway, so it wouldn't really matter. But today is going to be a really exciting day, I think. We're going to dive deeper into some of the technologies and techniques that really facilitate MIS. We've got amazing speakers, and we've got a very busy program. As Juan is setting up his presentation, I'm just going to walk you a little bit through the day. So we're going to have a number of presentations about navigation, robotic surgery, total navigation, and then we'll have a breakout session. And we're going to have two breakout sessions that are essentially parallel today. Upstairs here and downstairs again, we're going to talk in one room, we're going to talk about robotics, navigation, and augmented reality. The other room is going to focus on more on augmented, no, one room is going to be robotic surgery and MIS. The other one is going to be 3D navigation and augmented reality. I want to encourage and ask the faculty to make sure that everybody brings some really good cases, of course. And we're going to have our Socratic debate. We're going to have a debate between proponents of robotic surgery and those who are a little bit more critical. And then we're going to have the abstract presentations. As you know, for this first year where we asked people to submit abstracts on augmented reality, navigation, robotic surgery, and we got a lot of abstracts in, and we had a panel of judges, and we picked the three that we thought the three best abstracts, and those are going to be presented as oral presentations. So I think that's going to be a really interesting presentation, and really looking forward to that. And then in the afternoon, we're going to again have a bunch of presentations and another breakout session. All right, so we'll start with our first presentation. It's my great honor and pleasure again to welcome Juan Uribe. Juan Uribe is a neurosurgeon who's now the head of spinal surgery at the Barrows Neurological Institute and the Volker Sonntag Professor of Neurosurgery. As you can see, he's obviously one of the really key experts and pioneers in MIS surgery, has really pushed the agenda of MIS surgery over the last years, and is an excellent surgeon, great educator, publishes, and one of those individuals who really are always a pleasure to have in any meeting, and especially obviously in our meeting here. Welcome back to New York, and thanks for your presentation.
Thanks very much, Roger, and thank you guys for coming that early today. I know that it's not easy, you know. Oh, you had Roe Isaacs in here. So now this course is amazing, you know, getting through the years. If there is something that has been pushing and helping us to put MIS surgery somewhere is Roger and his course in New York. You know, and everybody knows the Roger Hartol course. It's not even say Cornell, they say the Hartol course. So, but it's amazing, you know, because it's wide open. There is room a lot for opinions and criticism, and so that's why we love it. And it's like this last meeting of the year, most of the time for most of us. And this is when we end up like, okay, what we did this year and how is the state of the art on MIS. And Luis is not in here, but Pimenta come with something crazy like this year now with the prone lateral, and every year come with something else. So what I'm trying to talk today is a little bit of when it comes to deformity, when can we use MIS techniques or not? And which is very interesting because the more technology comes, the more we start trying to make and tackle more complicated cases. And now I have Dr. Pimenta. I was talking about the prone lateral, but yeah, I'm glad that you show up early. What time is in Sao Paulo right now? 2 hours. Okay, so. Oh, you're good. See, you sleep too much. Okay, so this I just want to show you this slide that I like it a lot is because I'm going to show you what's real story with the spine. And when Lenke and Shaffrey and Chris Ames and Chabez, La Martina for the European guys. Look at this, they don't like it too much. And because this is what's pretty much happening to me on the world, the spine and deformity. So this is like the phone in the 80s, something like that. This is what we're using right now. This is the cars of the 60s, something like that. This is what we're driving right now, efficiency, less, footprint on the contaminations, you name it, more efficiency, everything. This is the spine of the 80s, 90s, and this is the spine of today. This is bullshit, yeah? I mean, how come you can be doing exactly the same thing that we were doing 60 years ago? I mean, this is crazy. So what about we come with something different? And this is what we're trying to do right now. Obviously, this is not the correct answer. Hopefully, we end up somehow taking out of the equation the screws and doing something different. We're talking about 20, 30 years from now. But I'm trying to give you a little bit of a tour. When can we use these MIS techniques? And the reason is because we need to keep this population, we need to keep them going, and this is what's happening. We're not dying of 70s anymore. We're dying of 100s, this is different, And these people come to you and they ask you, Dr. Uribe, if I cannot play golf, if I cannot dance, if I can enjoy the life, it doesn't make sense. So you need to give me a surgery for my deformity. So, and then you keep opening people like this. Is this sustainable in an 84-year-old patient? I mean, that's crazy, yeah? So, it's some heroic cases when you see these open guys, what I call the butchers, you're talking about Lenky, Shaffrey, all these guys. They come and they say, oh, no, because now we're doing like a 1 gallon of TXA per case, and we are able to control the bleed, and then we put some belts and suspenders. Now we're using even shoestrings at the proximal thing to prevent the PJK, that ties. So, but I would say, I don't think this is sustainable, Nowadays, handling all these things on this aging population is very complicated. So what about instead of that one, we come with something like this, when the footprint is less, but still without compromising that. The problem is sometimes, because minimal invasive surgery comes as a great marketing tool, we have people unfortunately abusing that and using it when it's not indicated. So we'll see, for example, these 4 cases. And I'm gonna ask Holman there. Paul, how we doing, man? Good. So listen, so I'm going to ask you, Paul, is this case you think is feasible doing MIS surgery?
Yes.
Okay. What about this one?
Yes.
And this one?
We need some more film, but
okay, I'm going to show you more film. What about this one?
probably not.
Okay. So see, we're on the same page. So, and then the problem is when we look at this, same question for Paul. Can you still do this one MIS? Yeah. Can you still doing, oh my God, this one MIS?
Yes.
Okay. And what about this one in here with this nice gift around this area?
Maybe a hybrid.
Exactly. So we kind of the same page. So it's very interesting because if we go back, how long, Dr. Pimenta? 10 years ago, we were struggling doing this case right. We were able to put a bunch of lateral cages and some percutaneous screws, but then we were not really giving the lordosis that the patient needed. And it was a combination of misunderstanding of deformity and that. So as Paul mentioned, ideally we should go MIS on these cases, means percutaneous on the back and interbodies from the front or from the side. But sometimes, unfortunately, we have to use what we call hybrid. And to me, hybrid is like, for me, like the coward, it's my coward response to managing deformity, because I end up doing the whole thing open and taking the risk of the MIS. So actually I'm putting together, opening the patient to open techniques, complications on MIS. So something that we're trying to avoid, and as we understand and we get better on MIS, we're doing less. So then, we're trying to come with these complicated things. I hate this. I'm in here and we always support this, and we like 3 versions of this algorithm, how to treat MIS deformities. But because I like to see life more simplistic, so ignore this, and I'm gonna show you, you guys probably seen this one multiple times, but to me, life is very simple. I want to see things more clear. So to me, the patients with deformity come in three types. The patient that needs very little correction. You see here, these patients are totally imbalanced. The patients that they have a significant compensation phenomenons, and then obviously the patients that are totally deformed. These are the patients that the guy who taking care of the parking lot makes the diagnosis, and they say, you're going to Dr. Uribe's clinic because they come in walking like that. That patients, unfortunately, I don't think MIS techniques can do a good job. And usually I send it to my open guy on our group, and he just go and split the patient in half, and you name it, all these osteotomies and that. So these are the basically, so patients that we call in green that has very little deformity, the real deformity surgeons, quotation, they go and tell you that's not a deformity one, but then to me, still these patients, you have some deformity and you don't stop the progression of the problem, then you have issues. Then the second group is the most complicated one. These people are using every compensatory mechanisms, high pelvic tilt. Then the lordosis is just right there, but when you compare it to the pelvic incidence, you're short. And then obviously on the severe deformity, it's very tough one. So the game is, you have the patients in your clinic that is in here on the left, and then how do you know this patient is going to this group and not to this one of these groups, yeah? So that's when it becomes very interesting. So we have also not only execute good technically, but also we need to be very good in choosing what patient is good for what. And this is what I'm gonna do in the next, believe how much time we still have. In the next, 5 minutes, 6 minutes? Okay, so you see here, this is very important. You don't consider these factors that I have in here. The spine deformity correction is very complicated. Okay, age, it's different to treat a 90-year-old person than a 50-year-old patient. Bone density, if you don't have a good bone, in my own world, for a deformity, I will say worse than -2, I start thinking on something else but surgery. And then obviously pelvic incidence. Pelvic incidence is another bad enemy of the MIS surgeons. The higher the pelvic incidence, the more complicated the surgery because the more lordosis you need. So you want patients ideally with less than 60 PI, but you make sure that you don't get that. And then obviously, where is the lordosis? What is the apex of the lordosis? This is what, you come with the Russoli or all these new concepts on deformity. And then very efficient on 5-1. You're good in 4-5 on 5-1, you can do whatever you want. If you're not efficient on these two levels, you have a lot of problems. And then obviously, you have to know what procedure is good for what. When is T-leaf good? When is A-leaf good? When is the lateral good? So then you're looking here, this is I would say a red case to me. In my own hands, doing this case only with MIS techniques is very complicated. It's too much deformity, not only in the coronal, but also in the sagittal. So, you may end up doing something and then you end up creating a different problem. And what you do is you're actually trashing MIS surgery, because then this is the classic patient that goes again across the street to the open surgeons and they say, take a look what these guys do. And then they show it all over the world in every meeting and they say the MIS is bad, yeah? But then watch this one, for example. This is a great example of MIS. This patient has a very minor deformity, 20-something degrees of coronal deformity. The lumbar lordosis is pretty much good. So this patient, did not even see what I did. This is what I learned from Dr. Pimenta. 3 levels, standalones, lateral. You stop the progression of the deformity. You open indirectly the concave side. You see here, minor correction. You keep the lordosis, but this patient, deformity is not gonna keep progressing. Very low morbidity procedure. For an octogenarian, you cannot have a better choice than this. And then let's go on, for example, in yellow patients. So these patients are the more interesting ones because these guys, they come across like they're good, but when you look at the numbers, you see this patient, for example, is missing, 15, 20 degrees of lordosis. So you need to make sure that you deliver that lordosis. And in order to do that MIS, we have few tricks. Probably the more efficient one, as we know, is the ACR or facetectomies, MIS, and then trying to put hyperlordotic implants. So this is what I call a yellow patient. So you see here, kind of flat, and this patient has a bunch of osteophytes. And it has something that I like it a lot, which is the vacuum phenomenon. So when we have this vacuum phenomenon, we know that levels work with us very good. It just means lordosis for free to me. So you're looking here. So the challenge in this case is, can you go and destroy these osteophytes and remodel that level again? And you look here inside the OR, you see there's an ACR here. So in this segment, sorry guys, I have a lot of volume in here. And then once you get that, you can go actually percutaneous, past your rod. This is something that you guys do it all the time, but what I'd like to show you here is, take a look at the CT to CT pre and post. You see how nice these segments where it was a significant kyphosis. You look these two segments, how they actually open up with the ACRs at both levels. It's amazing how efficient is this technique when you do it right. Obviously, it has its own complication that is not the time to talk about that, but then you're looking here how nice it looks. And I mean, don't forget, this is part of my, what we call my butterfly collection cases. They're my beautiful cases. We have a lot of complications as well. And then I want to show you this other case. This is what we call a red case. We're using, for example, nowadays, you're using here, when the time comes to put the percutaneous screws, when we use this guide wireless technique, I would say, just sharp technique using here, it takes basically, this video has pretty much no editing, and it takes, no more than 1 minute, 1.5 minutes per screw placement, which is very good when you're trying to put 22 screws in a case. So you have to flow. Using here, you just put the screw there, 2-3 taps, and then you advance the screw. So you take out of the picture the guide wire, the jump shooting needle, the tapping, all these redundant options. And using here, it goes very smooth, and that's the job. And then we use this computerized technique to find what is the size of the rod and the length. And then in this case, as you see here, we can really deliver a good job, and we can actually see this was an MIS case that I don't know what they did in here. It was crazy. So we're able to produce a more predictable surgeries. So just to finish, I want to show you a little bit of pictures when you do ACR. You see how efficient it is giving lordosis. And sometimes we have to mix open techniques. This patient has a PSO in this level, plus the percutaneous on the other levels. But in cases that are complicated, you can see here, we can still throw percutaneous the rod, do an PSO on the lower below, and ACR on the level on the top. And you see how these severe cases that I call it red, they can be more complicated. So in conclusions, MIS surgery, MIS spine procedures are very useful in deformity. You need to be careful when to use it and how. Thanks very much.
Thanks, Juan.
Thank you, Roger.
Why not just connect those incisions? You showed us all the percutaneous. Why not just make one incision?
Because you start having a lot of seromas. And you know what, I'm going to tell you, in 2009, 10, so I don't know, you guys know Mark Dekutowski? He kind of disappeared a little bit of this, yeah, he's kind of fading. So I was, trying to do incisions like that, and then Mark Dekutowski come, why don't you make an incision? And then Neil Anand was like, oh, great, let's do it. Well, Neil, everything works perfect for him, yeah? So we say, and I always debate with Neil a lot. So I say, fine, I'm going to start doing it. So I start doing this midline incision, doing this subcutaneous dissection, and then going onto the Wolsey plane. So it's easier because at the end of the surgery, you pretty much see everything. It's like an open there. But then I start having a lot of seromas. A lot of patients you get called from rehab, when they go to rehab, Dr. Uribe, we have an issue here on the skin and that. And my blood loss start getting up. So I decided to go back to these stab wounds. And what I do is watch. Lately, actually, the fellows are amazing because they always help you to make things better, yeah? So like when I came to BNI 3 years ago, my fellows say, Dr. Uribe, I like your technique that one by one, but we still losing blood, So let's say, why won't we put a screw, and every time we put a screw, right away we suture that. It talks about when we use modular techniques. And doing that thing, I've been able to do, I will say on the last year and a half, every time I do T11 to iliac, I rarely have to transfuse people, you know. It's like I think I can control a lot that, and then I don't have issues on this wound. Obviously, it's more work, but I think to me, it's a true MIS technique because percutaneous through a very small incision, you don't have this big dead space. I mean, obviously, a lot of you guys do 1 midline incision and do that, but that's what I do it.
Yeah.
Luis.
So,
Yes, sir.
the first thing, great talk again.
Thank you.
But you talk like a deformity surgeon. So you start saying that in the list of indications, you start with age, right? What about the symptoms? Because we are discussing x-rays here. So we still do surgery to correct x-rays?
Yeah, that's a really good point. And, you know, obviously, you know, I have 15 minutes to show this, but I always say that we treat people, we don't treat MRIs and x-rays, yeah? And a lot of cases, patient comes with a significant deformity and he only had leg pain. My procedure is a little foraminotomy at that level, you know. Sometimes we're trying to do short fusions. You know, obviously, as I told you, I was showing my butterfly collection, you know, cases that I was trying to get to replicate what the open guys do it. But it's a lot of cases where my numbers are not really matching, but the patients are happy, and you do a much smaller procedures.
So you don't think that doing less invasive, we could maybe in older population do less surgery,
Yeah.
You know, less levels and be more concentrated where the pain comes from?
Yeah, and I think
like
that's
stenosis, right?
Yeah.
You go to the level of stenosis.
Yeah, and I think that's part of the philosophy of MIS surgery. You not only do less invasive procedure, but also try to do less surgery, you know, and I think that fits the bill.
I think my you know, MIS, in my opinion, should mean minimal instrumentation surgery. So, you know,
Yeah.
so,
Yeah. The thing is that we cannot burn bridges, you know, because we cannot make sure that because we say that, then we abuse it. And that's the last case that I showed with the 3 unilateral perk screws, and then the patient came back, you know. So that's what the know-how is very important in here. When you can really do a small, and this makes it more complicated what we do. For the open guys, it's very easy. I always say they only have 3 speeds: T10 to iliac, T6 to iliac, or nothing. They don't have any other surgery besides that.
So,
you know?
Juan, do you believe that degenerative scoliosis is a progressive disease?
It is. I think it is.
And do you believe then that we may be doing preventive surgery?
Yeah, and the problem is also we're creating, you know, that PJK thing that still we don't know how to control that. You know, you do a beautiful surgery that lasts, 6 months, 2 years, and then you know what you do. So yeah, I think like the case that I showed at the beginning, the standalone cases, that's an amazing case. If we didn't catch that patient at that time, in 2, 3, 4 years, probably will be a guy needing osteotomies, you know, to be within the number. So it's tough. The thing, what I like is with the standalone, for example, lateral, is that the morbidity is too small that the trade-off is very easily. You know, I can do 3 interbody levels, get out of the OR in 2 hours with no blood loss, patient go home next day. You know, try to do that one open. I mean, 3 T-lips open, and that's a big deal surgery, drains and, you know, all these things.
we gotta move on. Taylor's trying to keep us on time here. But just in transitioning now, tell me the 3 key enabling technologies, in your opinion, for MIS. Just very quick. The 3
Very
key-
simple.
Yeah.
MIS lateral, percutaneous screws, and 5-1 A-leaf, you know, less open. I think with that one, you can do everything.
Great. Thank you so much.
Thank you.
Thanks, Juan. So we want to transition to the next speaker, but before we do that, we have everybody here. We're going to have 2 breakout sessions today, and they're going to be on robotic surgery, MIS, and the other breakout session is going to be on 3D navigation and augmented reality. And I want to remind the faculty, please, to all bring cases. You're all assigned to one group or to the other, and we're going to do 2 breakout sessions on those 2 topics today, but please make sure that faculty has cases. So we're going to introduce Robert Eastlake from San Diego. Thank you very much for being here. very, very involved in obviously a lot of MIS surgery-related activities, but especially navigation. And we thought it would be worthwhile to talk a little bit about navigation and how to bring navigation to the next level and make it more efficient and successful.
Thank you very much, Roger. Thanks for having me. So this is a great launch after Juan's talk, and I'll give you some basis for it. This was something that Juan, Greg, and I had talked about over the past year, not the least reason of which is because we have this exciting new technology, but not a lot of great analysis on how to implement it and where it fits in and how to use it more often. So with that, I don't have any relevant disclosures to this topic. The history of spine study groups, and of course there are many outside of that, is fairly extensive, but it really is on the heels of the issues that we have with clinical trials in general with surgery, and certainly in spine. We tend to have a limited number of subjects. None of us do thousands of surgeries each year, so there's some variability and limited numbers within our own clinical practices. There tends to be a significant amount of heterogeneity, which is harder to look through on a single center basis. And then there's a bias in patients and surgeons that bleeds through that data. So even the best of our clinical trials gets a bit challenged. Our sport trial is a good example of that. Now that had a lot of crossover effect, but the reality is we need substantial numbers. So we need the recruitment of many centers to get good quality data from which to determine patterns and recognize issues. One of the first well-known spine study groups was the HARM study group, and that was launched really initially looking at idiopathic scoliosis and its treatment. And of course, Jürgen is a foundational member of the spine community. And from that initial study group, there became many study groups. You can see here a list of some of them: Growing Spine Study Group and ISSG are some more well-known groups. And then, specific areas of the spine as well, like cervical spine study groups. So these have come about to do exactly what I mentioned, which is to look at problems in a more multi-center and higher data throughput way. So bring in navigation robotics. This is a technology area that's advancing much faster than our understanding. So the companies, in a very good way, are creating this technology, yet we don't really understand on a heavy analysis what it costs, what the workflow, what the efficiencies, and other issues are in implementing it. So adoption generally has been slow. Navigation's been around for a couple decades. And this is actually a paper from Roger back in 2013. And in a survey, only about 11% of spine surgeons were using computer-assisted nav at that time for a variety of reasons: cost, workflow, availability. And I think there remain some serious questions regarding the value proposition of these technologies that have yet to be answered. And those value propositions are not just from us, they're from the hospitals. I'm sure all of you are aware of hospitals that refuse to purchase these things. And then patients think they want the fancy robot, they think they want navigation, but they don't really know what that means. And if they had to pony up and pay for it, I'm not sure all of them would if they knew what the data showed. So there's a different perspective that we have to consider in that. So two questions that I think we should consider as we try to get to that point where it's an irrefutable fact that we should be implementing these. Why have navigation robotic systems not widely populated surgery centers or surgeon-owned, if you will, profit centers? I think we all know the reason for that. And then what percentage of nav and robotic systems have been purchased without a consultancy arrangement or implant deals? If these technologies can be shown to be truly beneficial, theoretically they'll have standalone value. They won't need to be sidecarred with implants. So back to the study group idea, there are lots of things we need to learn. These are going to center around radiation safety. That's all dear to our hearts. Accuracy issues from our traditional techniques and how they compare to these new technologies, economic considerations, the value proposition, as I said, And then this concept of dashboarding. One of the great things that we've gotten out of study groups like GSSG or ISSG and the others is we learn from our colleagues. There are ways to implement these technologies. We learn the workflows, and we learn from one another as this data comes out. But we also learn just by getting together and say, hey, how are you doing this? How have you managed this problem? So there's a collaborative effect. One of the genesis areas of this new technology is our concern of irradiation. It's a major concern for all of us doing MIS, and one of the rationales for using NAV in robotics. Projected lifetime cancer risks studies are out there. The literature's not replete with it, but you can see here there's ranges from 1.5 to 17 times the risk of cancer. This is a study that's more specific to female orthopedic surgeons, and they had an 85% increased cancer risk and up to 200 to 300% increased breast cancer risk. So there's definite concerns with this. And it's good to just reflect on what sort of typical doses are, what occupational limits are. You can see an annual nuclear worker dose limit's about 5,000 millirems, but a whole body CT is only 1,000. And I want you to keep that number in mind as we go into this study that I'm about to show you that gives some foundation to a study group like this. So this was an analysis that Jake Godzik started putting together, and he's a fellow of ours from BNI, so collaborates on this research with Juan as well. And we wanted to look at the radiation burden doing MIS deformity. If you have not done one of those cases with just fluoroscopy, it tends to be a significant burn. So we looked at mainly the deformity patients at this point. This is a combined site analysis, and we looked at the magnitudes of the deformity and things like DEXA and BMI to correlate. But the bottom line was, as you can see here, we're really looking at the emission, not necessarily the received radiation, and compared it to ALARA, which is as low as reasonably achievable. We had 52 patients between the two, and the deformities weren't grave. They're sort of in the standard mid-range of MIS deformities, but averaged 5 levels, and 40% of them were revision cases. But this is just a good look at the range that we would see. So here's a range between 29 milligray and over 1,000 milligray for one of these cases. That was clearly Juan's case. He's probably still glowing from that one. But just to give you some clarity on what that compares like, a chest CT is only 90 milligray. So that one case was 10 times a typical chest CT. And then if you compare those numbers to the occupational limits of 150 millisieverts up to 500, depending on the part of the body, that's a lot of radiation from one case. So if you're doing MIS deformity with fluoro, it's something to be concerned about. Accuracy concerns are out there, of course, in open and fluoroscopic guided, but the numbers are all over the place. And so part of the value of a study group is to figure out variance in that arena, in the baseline arena, including complications, and then compare it with these new technologies. Advancing robotic systems are improving. This is a list of some of them. And then look at the cost effectiveness. We have major assumptions in some of these older papers, including this one that looked at improvement with robotic systems, and they had less infection risk with robotics. Unclear why that would be. No fixation revision rate with robotics. That defies logic, and certainly our experience revising patients that have had robotics use, and a fairly limited dollar per minute time. So that tends to go on in the literature where there's these assumptions made, or as in this paper, an infection rate that was 10% in the open group, which is significantly higher than what we've seen certainly in the ISSG, and even 2.7% in robotics. So we have to get better data from which to make decisions. Ultimately, we are going to have to factor in radiation exposure to this, including looking at technologies that drop the burden of radiation. Examples would be less ray. Control rad's a new technology add on to fluoroscopy that allows us to diminish radiation emission by 80 to 90%. So maybe we can do standard fluoroscopic guided surgeries with far less radiation and not have to worry about that issue anyway. So factors to study in the group would be things like protective mechanisms. How does our behavior in the operating room affect our actual reception of the radiation versus the emission? Define the occupational risks a bit more. Wearing lead, for instance, day in, day out is not the greatest thing. Could be an occupational hazard not yet evaluated. Surgeon variance with all of these new technologies and the old techniques, and looking at efficiency, accuracy, and the cost involved in applying them. So the opportunities are out there to look at many things that will make us all better. And in conclusion, we really need a robotics type of study group, multi-center, so we can collaborate and learn from one another to provide for better data in a prospective fashion, not a retrospective, limited manner. Align the needs of clinicians and industry so we can answer the right questions together. That will be more powerful. Manage the analysis of rapidly changing technologies much more aptly than we've been able to do so far. Do comparative analyses across technologies with far greater ease, and then guide the evolution of the technology application in a much more responsible manner than we've been able to achieve thus far. Thank you very much. You bet.
Questions, comments? So what are the next steps in terms of potential study group, or
So one of the challenges of study groups is getting them funded. So we've sort of taken that on our backs initially, but long term we're going to have some industry alliance and support. Industry's been somewhat receptive, but it's not, at least thus far, it's not as big of a monetizable effort for them. It's not like selling implants. It's a far lower revenue generator for them. So we have to get them interested to do it in a setting where it's not their primary revenue generator. And that may be more of a challenge than we would like.
That seems very short-sighted. I mean, there's we've got endoscopic surgery now with navigation. We've got augmented reality. We've got virtual reality. We've got robotic surgery. We've got 2D navigation, 3D navigation. I mean, clearly, the industry is soaked now with stereotactic navigation type technologies. I mean, it should be in their interest to really support a group of surgeons who wants to put meaning into all of this.
I think there's interest out there. There's no question about that, and they've been receptive at the meetings we've been at. There is some meeting and study group burn on their end. We don't obsolete these groups. They just tend to keep being added on. We add more meetings on, and so the companies are a little shyer about throwing more money at it. But I think to your point, there's an interest. They're all developing these projects, and they candidly do need a way to validate them. There's pushback in the marketplace for outright acquisition of them. And so if we can, as a combined effort, generate data that really represents a value proposition that's less refutable, I think it makes it an easier sell for them on standalone.
I've seen... I understand this is the future. Don't take me wrong. But what I have been seeing in the market is the big companies, they want to have these nice toys to conquer surgeons to use their products. Yes or no?
I completely agree.
So that's not a very good start, right?
Right. I completely agree with that current paradigm. However, I think there's promise in the technology, and as we, particularly and more so with robotics than nav, as the technology advances to the point where it's more augmentative to our workflow, so it's a value add, it actually helps us become more efficient, regardless of accuracy and radiation safety. I think that there becomes a value there that allows them to sell it, and we'll be interested in getting it because it makes us better and faster.
Sorry, just a question. Obviously, there are a lot of barriers, and more studies are needed to convince people. But for neurosurgeons, craniotomies used to be done without navigation for decades, and now it's standard of care. Why do we think spine is so different when it comes to that? I mean, it makes surgery so much better.
I think there's some refutation that it actually makes us better. It often makes us slower.
We never needed those studies for the craniotomies to become standard of care when it comes to this.
Well, that may be true, but that's in spine. I think you have leaders in the field who are excellent surgeons, and it doesn't necessarily make them better in terms of accuracy, safety, and then revisions, things like that. Those are still matters of debate. We need to make that less debatable and have clear data, meaning we need to define ranges too. I think it's unfair for Larry Lanke, or the best of the deformity surgeons as an example, to say, I don't have issues with placement of screws. Well, the world's not populated with Larry Lankes. There's a bunch of spine surgeons out in the community that can actually be better and do better surgery more safely with robotics or nav in their hands. So we need to define the variance a little bit so we understand, okay, maybe for a certain small group of surgeons, it doesn't value add in that category, but on blend, it's a huge value to our health system in general. So it's a different perspective, but that's the way I'd look at it.
All right, thanks.
Yeah.
Larry actually says he would use navigation if it was more efficient.
Exactly
Yeah,
right.
so, but I think the difference between brain and spine is, navigation for brain makes wrong side brain surgery impossible, which is a huge deal. And in spine, we just really haven't looked at wrong level surgery, which navigation also makes impossible. But I think we should really kind of look into that, the lower incidence of wrong level surgery with navigation versus without. Yeah. I want to introduce Robert Isaac. Is probably one of the smartest people here in the room. That means you're probably in the wrong room then. But certainly a big innovator, and has done tremendous work for navigation, for radiation exposure, and so thanks for being here.
Thank you. Well, I clearly don't justify that, but thanks for the nice introduction. I'm here to talk about some other thoughts in terms of computer-assisted surgery. So I have a number of conflicts in this space, and I'll try to be cognizant of that as I move along. Now, we've talked about a lot over yesterday, and as we move on to the rest of the meeting, this is a meeting that is geared towards looking at what is the state of the art and what is out there right now in terms of navigation, robotics, and this technology is amazing. There's no question about it. The abilities of this technology is really cool, and I think the sight of what it can become, I think we all share, is that there is something there, there's something substantive there, and the technology that's come about in the last couple of decades is incredible. And what's coming, and what we saw yesterday a little bit, and we're going to see more of today with heads-up displays and instantaneous rendering and things like that, we're looking at stuff that really gets to the heart of very, very cool. But remember, as physicians, we're not necessarily about what's cool, we're about what's functional. And so when a person walks into your clinic and they've got, I don't know, a single level slip at 4-5, it's a mobile slip, no overt stenosis, some foraminal disease, and a lot of radicular pain, and they claudicate. The question is that the best case for a robot or for a 3D nav system? And maybe it is in your hands, and maybe it isn't. And the reality is you have to look at that objectively. I think that's part of what Bob was trying to allude to, is that, we look at this, we can say, yes, maybe it's a great technology, or maybe it just adds 30 minutes or so to your basic, 90-minute T-lift, or your X-lift per screw, or your single position case. And maybe it even adds more if proportionally it doesn't add a third, it adds 40% or 50% of time to your case. And that may be okay, because, Bob also alluded to a lot of radiation. Well, there's an awful lot of radiation associated with CAT scans and with intraoperative CAT scans. And are we subjecting our patients to more radiation than they would be subjected to otherwise? It's just something we need to think about. I'm not saying that there's an absolute right or wrong here. I fully agree that there needs to be more of this understood. And you could make a really strong argument that, yes, if you look at systematic reviews, you look at meta-analyses, you look at the data, you're going to do better at putting in perfectly positioned screws when you use these types of technologies. And so, drop the mic, I'm done, better positions of hardware, which is effectively, let's be clear here, that's really all they do right now in terms of the robots. I think there's an opportunity there, but it's not necessarily what has been done at the moment, what has been achieved. Partially that's FDA issues, and I agree with that. But if you then really look at the data, I don't want to download something. Remind me later. You see that actually, an A and a B is a well-placed screw. It's a highly functional screw, and there is no statistical difference in a well-placed screw between these technologies and freehand. So maybe we don't need them to be better surgeons. And as was stated in the last talk, it's going to make surgery a lot longer. And so that is clear in the literature. And when I do a fluoro case, I'm not sure that I've ever put in egregious screws. But because you're relying on a reference array that's placed on the patient, they get bumped. Those are perfectly parallel, perfectly beautiful screws, perfectly through the center of the canal. And you'd never do that if you were using fluoro. And so I'm not saying that happens all the time. I'm just saying that there is something that we need to talk about as surgeons, and we need to study this. There's no question about that. And if you look at our data, this is, percutaneous placed pedicle screws in the early 2000s. We're talking, almost 20 years ago now. That's how old I am. That's 0.3 malposition rate and several hundred screws, CAT scan proven, no image guidance. So you can put in safe hardware percutaneously. And so I sound like a naysayer, and I'm not. I actually think the technology is amazing, and I think the opportunities out there are incredible. But the same thing that's happened over the last couple of decades is we've done more and more in terms of robots and navigation systems is the technology, the computing power, the rendering, the graphics processors and the like that are allowing us to do these types of technologies are also allowing us to do other things in the operating room, some of which have significant value. And I think we should talk about that too, because this is a meeting that's geared towards looking at those types of technologies. And so there's a number of them here, and we'll talk about even more. But if radiation is a concern, I think it should be to all of us. This was another paper that was pointed out in the last talk, is that, almost a 3x higher incidence of breast cancer. This is a problem for us. Okay, we do need to be conscientious of the amount of radiation we're getting exposed to. And there is 17 million fluoroscopic procedures in the United States a year. All right, and that's actually 2014 data, I think. So that is old data, and it's actually growing. So there's so many procedures. There's like 250,000 spine fusions, just to put it in perspective. There's so much fluoroscopy out there. It must mean there's some value to the technology, and there's no question you can get real-time confirmation. You've got something that's in your operating room. You're always flying on current information. There's some value to fluoro, and you can confirm what you're doing in real time, and that's super important. I think a lot of these technologies clearly don't allow us to do that, and that is a limitation of them as they stand today. So for people who like to use fluoro, there are ways to decrease the amount of radiation, and this was talked about in the last two talks, actually. You can actually decrease the amount of radiation by hitting a couple buttons on a fluoroscope, add a third, and you can even decrease it even further. What does that look like? It looks like it's an unusable film. So the problem is that decreasing the radiation also decreases image quality, and that's where one of the two technologies, this is less-ray, comes in. It allows the image to be reprocessed in real time that is what's on your fluoroscope, and that's what's on the less-ray machine. So use much lower radiation images, yet still achieve the value of the fluoroscopic shots. And the key here is continue to take x-rays and confirm what you're doing in real time and make sure you're not flying on information that was done last week or a month ago or even 4 hours ago, but current. And the data looks like it actually works. So an internally randomized controlled trial shows 75% radiation reduction, not just to the entire OR staff, but also the patient as well as during every part of the procedure. The other technology that was also mentioned in the last talk is the control rad radiation. That's also come out fairly recently. In this idea, it's actually kind of cool. What they do is they point, and they pick a region of interest. And what you realize is that that's actually what you're doing at the moment. And they can limit the collimation around that, and therefore allow a high resolution image in where you're looking at a lower radiation image where you're not, where it blends out and it becomes less needed. Here you go is a soft disk at T1011, T910, and as Roger alluded to in the last talk, how are we supposed to localize that? Level check is a rendering technology that allows you to accurately check the levels. In theory, the problem is not FDA cleared, so the data looks pretty good. And then less-ray has an option for that as well. We're trying to do preoperative scans for patients and try to make sure we understand how to get the correct balance and how to make everything look good. And if you're wanting to rebate, it always looks good post-op. And so that's what our goal is. But how do we make sure that happens interoperatively? There's various apps that people have on your cell phone that can look at small images. LessRay allows you to do it across the entire image and get some of the larger things. And then this was talked about in Juan's talk as well, which is, and you can form a rod as well in real time. If your concerns about hardware are significant, then there are ways other than nav systems to do it. At one extreme, you've got SafeOp and NeuroVision in terms of looking at stemming screws. This technology uses impedance in a similar way and also achieves 97% accuracy according to their studies, which is very similar to what robots can. And the last technology, the one we're working on currently, which is a virtual live fluoroscopy, put a snap on an instrument, and then that becomes a way to track an instrument using fluoroscopy instead of using a nav system. So it's your standard instruments you use. Inside the circle, your instrument will show up aligned to the arrows that were on the last image. And more importantly, as you move it, a virtual rendering of it moves to the right location. You put it where you want to, and then when you take a shot and confirm it is in the right spot, instead of taking and jabbing aimlessly at the patient, trying to get it in the right spot, you're actually doing it more elegantly. In real time, that looks like this. You put it in, you take an image, you move the instrument. As you move it, you can watch it in virtual live fluoroscopy. That's all virtual, and then that's it. So, and you can do it in 2 views at once. And it works. Radiation reduction of 83%, but more important, time saving. So a couple hours of OR time saved in the first 10 cases that were done. So that is the value of actually getting the time savings we've been looking for with navigation type systems and using the similar technology. So it's out there, guys. This stuff is really cool. It's coming in all directions. And we need to start thinking about how to integrate that into our practices so that we can continue to gain value as the technology and the people in this room keep pushing it further and further. Thank you.
Thanks, Robert. Any questions? Luis, any comments or questions?
Yeah, explain me better. I basically understand that this is more simple to use for surgeons, the TRAX-X, compared to a full navigation system based on CT. How about, the same level of quality or precision?
All the systems use the same exact cameras made by the same manufacturers. They all have the same level of accuracy. The question is how you then present that data to the end user. So the one you're talking to, TRAX-X, the idea is rather than go and link the pre-op CAT scan or the inter-op CAT scan to what's happening at the moment, all we're doing is linking it to where the x-ray was taken. And so we're giving you kind of the same level of accuracy, but without a patient array and based off of the x-ray. And then as you take x-rays during the procedure, everything re-registers. So this concept of re-registering is key, I think, and that's what 7D, which I don't know if it's being talked about today, is really cool, is that they re-register during the operation. This re-registers on every x-ray you take. So it's always giving you the current information, the information off the last x-ray, which is in some ways really great.
A lot of us do really well in eliminating fluoroscopy, and we do a lot of our cases now purely on and that's the title of my talk, total navigation. The only procedure that we use fluoroscopy for is lateral surgery. Mm-hmm. And there are certain problems with accuracy and then updating images and so forth. In your opinion, what's the key challenge in totally navigating lateral surgery? What's the key challenge, and what may be the key solution to that?
I think that it's, I worry about cases that are flexible. So I worry about a flexible spine. I think that that's the key to navigated surgery is you're using a reference, often the hip, right, which is distal to an AIS case. Or in the case of lateral, you're looking at a spine that literally shifts. And if actually you watch it, it moves a good amount during surgery. They settle, and as I'm malleting on the patient, they literally shift down. And so this is hard for the systems that are using a distal point to, as a reference, to continue to reference and reference accurately.
What's the solution then? You can't talk
I'll tell you next year.
All right, thanks. Great talk. All right. So I'll talk to you about how we incorporated navigation in our practice. And I think it's been really fascinating, and Ilya alluded to it. We start as a resident, we started using navigation for brain surgery. And I always, for me, it was no brainer to then translate that into spine surgery, but it took really a good 10 years struggling in the OR with every case with the ISO-C at the time, where I had to do the spins pretty much myself because the X-ray tech didn't really know how to do it, and it took 10 years to really get it to the point where it was really efficient. And then now with the new technology, it's really totally streamlined, and we expanded it to the point where we, as I mentioned, we totally eliminated now fluoroscopy except for lateral surgery. I don't know if you watch YouTube or TED Talks. There's a guy, Simon Sinek, and he talks about the success or failure of companies, institutions. And he says that the mistake that we make, we talk about what we do and how we do it, but we don't really talk about why we do it. And he says that the reason why a company like Apple is very successful and other companies is they really address the why. And I think in spinal surgery, it shouldn't really be much different. And so why do we navigate? And I think the key aspect is really we want to be safe. It's, at the end of the day, it's all about safety for our patients, safety for the staff, safety for us ourselves. And I think navigation has a lot of advantages in that regard. I think data show now that it's efficient. I think in the old days, you could make an argument that it takes time and so forth, but now that the workflow has been worked out, and I think if you use it correctly, if your team is used to using navigation, it can be extremely efficient and can make you more efficient as a surgeon. And then it enables complex and minimally invasive procedures for many different reasons. And then more and more patients are really picking up on that. And if I call it GPS. If I explain to a patient in the office, we're going to use GPS to put in the screws and the instrumentation, patients understand that, and they will naturally gravitate towards preferring that versus doing things freehand. One of the key papers, and there are a lot of papers about this, but this is a paper that we published a few years ago, was that navigation really decreases the perforation rate so the misplacement rate of screws. Now, let's talk about navigation. And there's a lot of confusion when we talk about navigation. It's a complicated technological phenomenon, right? You've got imaging technology on the one side, and that's intraoperative and preoperative imaging. And that's really then a preoperative CT scan or intraoperative 2D or 3D imaging. On the other side, there's navigation technology. That's 2D navigation software, 3D navigation software, robotic, and now we have augmented reality and virtual reality. So there are really two different types of technologies that come together, and we as surgeons, we kind of have to fuse it together. We have to combine it, and it gets fairly complicated. And I think we should, and that's why I think a study group would be really good to really clarify the landscape for surgeons, for industry, because we use different terms for different things, and I think that makes it unnecessarily complicated. In my opinion, there's no difference between robotic surgery and regular navigation. It's exactly the same thing. It's just how you use it. And it's only going to get more complicated now with augmented reality, virtual reality. I think we really kind of have to clarify the landscape in order to really make sense of it and really define its limitations and its value. So, what I want to convince you of is that navigation at the end of the day increases implant accuracy, which is a good thing. It facilitates MIS and complex surgery. It eliminates wrong level surgery. I think as surgeons, we haven't done really good enough job of really pointing that out. A wrong level surgery in North America is a huge deal. Hospitals pay lawsuits, and we could really we could leverage that and to clarify that navigation eliminates wrong level surgery, and therefore, just for that reason alone, is incredibly beneficial and helpful. In our practice here at Cornell, we pretty much eliminated fluoroscopy for most cases, and now we start using augmented reality, and I'll show you a few cases, which I think is really exciting. And obviously, we'll see many more cases over the course of this meeting. Now, we use an intraoperative CT scanner now that is integrated with navigation, which facilitates the workflow. You can scan if you want. You can scan the whole spine. The image quality is essentially like a diagnostic CT scan. And once we started using that, the step from using navigation just for putting in the pedicle screws to using navigation for everything was very, very straightforward. So now we started using navigation for everything. We get a scan, we plan the skin incision, so you can plan the skin incision in a perfect trajectory for your pedicle screws. We use it for screw placement, and then we use it for placement of the tubular retractor for the decompression, for the cage placement. This is an example of a TLIF case. And then finally, when you get your CT check at the end, of course, we call that total navigation. I'm obsessed with accuracy of navigation. So people joke I should have invested in this 3M company that makes those surgical tapes. I really tape down the patient a lot, but it increases accuracy. Even if you have a patient who's fairly obese, you want to make sure all the soft tissue doesn't move, and that really helps you then with accuracy. There's a big problem with, as Robert mentioned, the spine and lateral surgery kind of bending. We don't have a good solution for that, but for some of the posterior cases, by taping the patient, you can eliminate some of this. We use iliac crest 2-pin fixation for the most part, and you can navigate very safely up to L1, maybe T12. And so we use navigation. We get a spin. We plan the skin incision in the perfect trajectory for the pedicle screw. We make those skin incisions, and we use the single tip or the single stage pedicle screws. There are a number of different companies now who have those available. They have a little K-wire that's integrated that penetrates the cortex, and the screw tip is very aggressive, and it's a single stage. So you don't need any tapping or awling. You just basically put in the screw, and we just submitted a paper comparing this to more conventional screw placement in terms of timing and workflow, and we saw that this overall works really well. And as Juan, I think he mentioned, a pedicle screw takes 1.5 minutes. If you average it out, it's about 2 to 2.5 minutes in our experience, which is much faster than the 5 or 6 minutes for conventional navigated pedicle screws, where you use K-wires and tap and all, and use 10 different instruments that you have to navigate. With this instrument, you navigate one instrument, and you put in the screw. Once we have the pedicle screw in there, we navigate the decompression. We navigate placement of the tubular retractor. We can identify the disc. Patients who have very collapsed disc space, the navigation can help you get into the disc space safely. And then we place the tubular retractor. We do the facetectomy, and the navigation can help you with that as well. We finally place the cage, and so forth. And then we do the over-the-top decompression. If the patient needs the over-the-top decompression, you can navigate that as well. It can show you whether you have successfully decompressed the lateral recess and the foramen and so forth. And this is the over-the-top part. You can see we can go over the top into the lateral recess and the foramen on the other side. Over the top, there's a movie about that. I just want to remind you of that if you're interested, maybe Saturday night on the way home. So, and then finally you get your final CT scan or X-ray, and you can make sure that everything looks good. We use it for bone harvest in the iliac crest and navigation for iliac screws. And then finally we expanded using it not only for instrumentation, but now we use it for pretty much every pathology. We use it for thoracic tumors, for thoracic disc herniations, cervical foraminotomies at C6, 7. I do a lot of cervical foraminotomies. Navigation makes it so much easier. You don't have to struggle with the shoulders. You don't have to struggle with X-rays. You navigate it, and you know exactly where you are. There's a thoracic discectomy, so you can get really beautiful scans. This is just an example to show you, even though the retractor's in place, you've got a lot of air, you still get a good quality scan here. We published our experience on total navigation, and we showed that we eliminated fluoroscopy in about 75% of our cases. The only cases, again, that we still use fluoroscopy is lateral surgery. There's a tumor case, an extraforaminal tumor that was done MIS with navigation. And by using navigation, it just facilitated the posterior lateral approach. So we avoid the facet joint, and we did this through a tubular retractor. We could resect the tumor under the microscope with navigation, and that just makes sure then that you got the whole tumor out. You preserve the facet joint. You don't have to fusion. You don't have to do a fusion. We do a lot of single-stage surgery now. We heard about that yesterday. There's a case. We had a fusion done and had adjacent segment disease above and below. We did an lLIVE from the front and then a lateral surgery at the level above. This was done single stage, so we did lateral surgery, lLIVE surgery, and then screws from the back. And this can all be done with navigation except for the lateral part of the surgery again. For that, we use fluoroscopy. And the challenge now is really to figure out how can you also do the lateral surgery with fluoroscopy. And I think there are a lot of challenges, but we and others are working on that. Putting in the screws in lateral position is a little bit of a challenge. One of the key aspects here is before you put in, when your patient is in a perfect lateral position, I rotate the patient. Then when I'm ready for the screws, I rotate the patient away from me, and then I get a scan. And that makes it easier to put in the screws on the opposite side. But you got to get the scan after you rotate the patient. If you get the scan before you rotate the patient, it'll be inaccurate. But if you rotate it later, this is one of those little tips and tricks that you learn when you do this type of surgery. No, the beauty now is that if you can't really trust your indirect decompression, you can still do a lateral decompression in a lateral position with tubular decompression. And as a matter of fact, having done now a lot of those, it's almost easier to do tubular decompression in a lateral position than it is in a prone position. And we do it now all the time in patients where we're not 100% sure, well, did we really get a good decompression with lateral or lLIVE surgery? We drop a tube, and then we just do a quick decompression under the microscope in the lateral position, and we use navigation for that as well. And it works fairly well, and it's pretty straightforward. This is an example where we did that, where we dropped the tube and with navigation here and did a decompression. And we have a poster on using 2D navigation for lumbar surgery downstairs. And don't worry, we took it out of the award session, so we didn't want to award ourselves the best poster, so don't worry about that. I want to show you a few slides about augmented reality. Augmented reality is an enhanced version of reality where live, direct, or indirect views of physical, real-world environments are augmented with superimposed computer-generated images over a user's view of the real world. It sounds very complicated. What it means, essentially, we use it with a microscope, and we inject images of structures that you can't see because they're under the anatomy, and you can see them through your microscopic view or through the exoscope, and it can help you primarily in your trajectory planning once you're in there. Now, we have a post on that. Again, we're not going to award ourselves, don't worry. This is a case, a sacral tumor that we treated and what we combined with augmented reality. So we marked it on the MRI and on the CT scan, and then under the microscope, we dropped the tubular retractor, and you can see the outline of the tumor here. The dura has been opened, and the tumor is right under the outlined structure. And we removed the tumor very successfully. Raj has it in greater detail as a case presentation, and that's the tumor coming out. This is a case where a patient had a big herniated disc and a synovial cyst at the level above. And we used augmented reality. It's a little bit hard to understand if you're not used to looking at it, but we marked the disc space. That's the herniated disc. That's the synovial cyst. So it helps you in terms of your trajectory planning when you drop the tube. Where do you do your laminotomy? How do you have to angle your tube? Can you get there through one incision or two incisions? So it helps you with all those little decisions that you have to make in the operating room. This is again, so we're looking through the microscope. That's the herniated disc underneath the dura and underneath the bony anatomy, and that's the synovial cyst further up that we have to address later on. Now, the last thing I want to show you is that we've done a lot of work with the AO and others on identifying workflows for MIS procedures. For example, we published a paper where we broke up the over-the-top decompression for lumbar stenosis surgery into multiple steps, and we can teach that with PDFs, with a real spine model under the microscope. We're doing the same now with MIS TLIV. MIS TLIV is a very, very standardized procedure, and it's based on landmarks. You can teach surgeons to do this procedure. The first landmark is the inferior laminar. Then you drill, you disconnect the inferior articulating process here. You're looking for the pars. The next thing is you got to find the pedicles to remove the superior articulating process. So those are all bony landmarks that you can identify on a CT scan, and then you can inject those into your view under the microscope when you do the MIS TLIV. And we did that here. So this is the disc space, this is the inferior edge of the, on this on the right side at L4-5, this is the inferior edge of the L4 lamina, this is the pars, and these are the pedicles. So these are all the landmarks that you need to do this operation. So we're doing a series of TLIF cases now where we use augmented reality to really find our landmarks very quickly. And that can be very helpful in patients with overgrown facets, for example, or patients with more complicated anatomy. So this is one of the potential useful applications of augmented reality. In this case, this is the L5 pedicle here. We want to make the cut right above the pedicle to remove the facet joint, and augmented reality shows you exactly where to make that cut and then where the pedicle is above. So that was really what I wanted to talk about. So I think that navigation makes you a safer surgeon, a more accurate surgeon. It's you know, you can eliminate fluoroscopy. We have to talk about the radiation for patients, of course. That's something that we still have to address. I think it can help you in education, teaching, training, augmented reality. I think we're just at the very, very beginning of really where navigation is going to take us. And I think we've got to make sure that we understand that it's really all the same. Navigation, robotic surgery, augmented reality, virtual reality, those are all related technologies. And we shouldn't separate them out, have industry separate them out for us. We should make sure that we look at it as an entity and find out where is it useful and how can we really integrate that into our treatment plan for our patients. Thanks for your attention. All right. I think we're a little bit over time. Or, oh, no? Okay, good. Any comments, Luis? Or?
I feel a dinosaur. So looks like in the future, we will not need to do surgery, right? We will learn the indications, then the machines will perform the procedures.
Well, that's true. You know, and the most important thing, we talked about the 6 T's yesterday. The first T was target, which is the indication. And we never talk about that, or rarely. What we talk about is the technology, the techniques, the teaching, the training, the research. All that, you know, we can automate. But the level 1, the target, that's something that we're going to be, you know, that's where we're going to be needed. Technically, maybe a robot is going to do the surgery, but the challenge is going to be the indication. And I think if we don't spend more time really becoming good at making indications and right indications, it's going to be a real problem because we're going to become technicians. And then if the robot does everything, then we're not needed anymore. Yes.
One of the challenges I think that we face with these new technologies, particularly on the training side, is we're starting to see people come out incapable of working without them. And one of the problems I have with that is you have less capacity to understand when something's wrong. And if something should fail in the midst of a procedure, it becomes a real liability for the patient and the surgeon alike. So how do you feel like we should be addressing that dichotomy in the sense of training individuals to go out and be able to master things well enough that they can use new technology but not be slaves to it entirely?
You know, I'll be very honest. You know, we have a project in Tanzania. You know, we go to Tanzania every year, and as we've been doing this now for more than 10 years. Initially, we went out there, and what we did was craniotomy for trauma, or, you know. Now, as everything becomes more sophisticated, you know, they want to do MIS, deformity surgery, and I could always say, oh, you know, you guys are not ready. But now they're actually ready, and I have a hard time putting in screws with K-wires and fluoroscopy. I haven't done it in 10 years. And you know, one of the reasons why, you know, and then Avelino still does, he goes to Chile, he does TLIVs in Chile, you know, and I admire him for that. I couldn't do it without navigation. And I'll be the first one to admit it, and it's a real problem. Fortunately, we've got 3 navigation systems here, so if one breaks down, we have 2 others. But it is a problem, and I think it has to. I think the solution is going to be a training program that teaches you the basics, and maybe we need a residency for spine surgery. You know, maybe it's not good enough to do a 1-year fellowship, you know, as an orthopedic surgeon. I think maybe we really need like a residency where you teach people the very, very basics so they can do those things, without the fancy technology. I mean, that's the only solution that I see. As spinal surgery becomes more sophisticated, we have to admit that, and we have to acknowledge that by really creating an environment where surgeons can learn the basics and the complex portions of spine surgery. And the fellowship is not going to be enough. As a neurosurgeon, we're a little bit more fortunate because that's part of our residency, but even that is not enough. So I think it's going to be a spine residency. Yes.
I think I'm imagining myself when they invented the X-ray and the discussion the doctors have, and when they invented the ventricular encephalograms, when the discussion the doctors have, and when they invented any new technology in medicine, they probably have something similar to this. There is something I'm not hearing from the physicians here, that when I use the navigation to do a craniotomy or a spine case, I'm still planning it the way I did it before in my head. Exactly the same way I did it in my head. I'm not as young as most of you guys. I came from the era where we were drilling holes to look for hematomas and so on. So what happened to the neuroanatomy and the neurophysiology? This is what makes us a doctor. So we're not going to be technicians. We're still doctors. We still have the three-dimensional concept in our head. So I'm not really concerned about all of that.
Yeah, but you have the benefit of, you went through that really great training program. You did it that way. A lot of the surgeons now, they leapfrog into new technologies and they don't even know the basics.
But this is our responsibility to keep physicians as physicians. You are a doctor, you go to medical school, you learn ABC medicine, and then we add the technology to it. I see the students nowadays put everybody in the machine. We cannot allow that. It's really our responsibility, and we owe it to the young generation to keep them physicians, not technicians. When I was in last year medical school, my mentor was trained in London, England, and the CAT scan was coming, and he presenting a case. I said, "Oh, we'll get a CAT scan." Well, I know something nobody else does. So the poor man looked at me, looked down the hole. The man that was cleaning the floor, he looked down and said, "What's this guy?" I said, "He's cleaning the floor." He said, "Tomorrow I'm going to give him authority to order a CAT scan. So we don't need you here." We're going to have to keep that in mind. If we don't keep the young generation doctors, not technicians, we lost the battle.
Yeah, I think that's why we need to talk more about indications and not only technologies. All right, so time is up. It's my pleasure to introduce Jason Perrin from Mannheim. He's going to talk about advantages of navigated robotics in a hybrid operating room setting.
Thank you. That's the pointer. So, good morning, ladies and gentlemen. First off, I would like to thank the hosts of this course for giving me the opportunity to actually give this talk with such, you could say, prominence in spine surgeons and this excellence of faculty, and then to have me as a young colleague of one of those leapfroggers, you would call it, basically, to give this talk here. So, as Dr. Hedler already said, my name's Jason Perrin. I'm from Mannheim. This work? Okay, well, it's not this Jason, but the other Jason. So we're here to talk about the advantages of navigated passive robotics in hybrid OR setting. I'm very fortunate to have this setting in my clinic, and I think I'll just walk you through it. This is my disclosure. As we've heard all the talks between yesterday and today, we've seen the advantages of spinal navigation and that it's becoming more and more established. Not as established as one assume, as we saw in the previous talk with 11% of surgeons using navigation, but I think we're on the way of getting there, just like in cranial surgery. And just quickly to skip through the common technologies, we've seen all of these, the 2D fluoroscopy, 3D fluoroscopy or 3D vision, and then intraoperative CT and mobile CTs. Well, in our setup in Mannheim, we have a bit of a unique setup. We have a floor-mounted robotic 3D flat panel CT. Basically, it's a comb CT. cone beam CT and a ceiling mounted curve system for the navigation. And this is what it looks like in real life, not to just so catalog images. This is basically the two large view displays, the control unit and the 3D flat panel CT. To put it short, it's an angiography system. And so we can use this for our spinal surgery and in conjunct with the navigational system. So, and in addition to this, as we've seen in the exhibition downstairs, and as we seen in many of the talks, we have robotic systems on the uprise, semi-robotic systems that are increasing rapidly. The technology is developing rapidly. And I like the slide that Dr. Hertel showed, but we have to fuse these technologies. We have the imaging, and we have the robotics, the reality, the virtual reality, the navigation. We have to fuse these technologies and suss out a workflow where these technologies intertwine really well. So yeah, I would like to then demonstrate this workflow of the fusion of these technologies that we've established in our department. We have a maximum range or maximum flexibility with a large range of motion with intertwining these two systems, so it makes it quite easy to integrate. And this is my personal evolution. Like I was saying, a lot of the colleagues here and the pre-talkers have years and years or decades of experience. My first navigated case on my own was October 2016. So it's just about 3 years now. And this is my evolution from starting with Yamshidis and alls, going over to the navigated drill guide, and then being fortunate because my boss ticked off all the boxes when he ordered new technology to have this passive robotic arm. And he just said, use it, make sure it works. So this is the positioning using in the hybrid OR, the standard prone positioning for radiographic markup. And I think we'll just go through the workflow because it demonstrates the abilities of the system better that way. And this is then the interoperative collision check that we perform to make sure there's the positioning of the patient doesn't endanger the system crashing into the table of the patient. You saw the rail there. That's where we're going to mount the robot or the passive robotic arm. The special draping technique to make sure everything stays sterile, and we could use it for fluoroscopy and for our CT scan. And then, as we've seen, we have the incision, the reference array. I think we can just quickly skip through this. And then we have our intraoperative image that we take where we're standing outside of the OR to eliminate radiation exposure. Again, I think this is a large subject that's already been addressed quite frequently. So we control this with the foot pedal. It takes about 5 seconds. Then here, don't be irritated, I changed my gloves and everything. I was just helping the smaller scrub nurse to mount this robotic arm to the table. And when we further drape the system, all this takes about 2 minutes. And then I kind of fling my gloves away and then continue with the surgery there. And now we can, when we've made our incision and we can just align up this system, it's a lock and release system. Neurosurgeons or a lot of surgeons that use microsurgery or microscopes will know this lock and release mechanism from using our microscopes in the OR on a daily routine. So that's why it's passive robotic. It's a mechatronic arm, you could say. And then you can fine adjust once you have contact to the bone, where you can pivot and move it and make sure that you have the optimal trajectory that you need. And then furthermore, you can, if necessary, like in the thoracic spine, you have the the ribs coming up, or the transverse process, you can wedge the drill guide into the bone to make sure it doesn't slip. And then this is a slide I like. I can optimize things if I have to, and seldomly, luckily enough, and I don't have to hold on to anything. So I can change the screw size and whatever I need to do, because all the products and implants in Germany are sterilely packed. I don't have a tray of screws anymore, so I have to make sure I pre-plan in real time, if possible, in the OR, and then order all the screws and the screw size that I need. And this kind of eliminates this factor where somebody holds a drill guide and then you just kind of optimize things. And I always drape my monitor and use it myself to increase work efficiency, because we also have a problem with lack of staff. I don't know if it's like that out here, but in Germany, I think that's a large issue at the moment. So this kind of eliminates that factor. I like to compare it to this. I can concentrate on something without endangering losing a trajectory or ruining my surgery in that position. So we kind of evolved to this kind of step now. So if I continue, then we'll just go through the workflow here again. We drill through the navigated drill guide. My resident kind of bored, turned into a one-man show, but I let him do the other side, so it's not like that. This is a cervical case, and then we place the K-wire. I know we've been talking about eliminating K-wires. We're working, or we will hope that this will come in the future, that we have a drill tap screw system where we don't need a K-wire and just place it through a tubular system. So we can skip through this, finally, a bit of action. And then we place our screws in a navigated fashion. So we can just set the robot aside. It doesn't take up too much space. It's not space consuming, and it's integrated into our workflow without hindering us. We don't have to move it around, have a scrub nurse or anything, push some machinery around, and then I can just park it up if I want to do an intraoperative scan to control my implants, and then it remains fixed to the patient table for the scan. It doesn't matter in what position. We have the same for the cervical spine. Sorry, I didn't turn off the sound here. And then just to quickly skip through, I think my time is running out, and for the thoracic spine as well. So we kind of evaluate the trajectories and compare the alignments of the plan, the pre-plan, the place screw, the navigated screw, the postoperative images, just to kind of evaluate that scientifically. So just to summarize, the advantages of this system, in my opinion, my experience, like I said, I was fortunate to have this system. I think I was, luckily enough, one of the first in the world to have it, and I've done about 70 cases with it. So I'll get to that at the end of the slides. Is to find out what's nice to have and what is a need to have. And I think this is a transition that has to be made, and you can only know this by using it. And I mean, we can all say and speak out against these technologies, but if we don't have it, then it's just virtual, not virtual reality, but it's just assuming things. But if we have it there and we use it, then we can actually evaluate and say what is advantageous and what is not advantageous about it. So we have a comfortable work economic due to its small dimension. It takes up only a little bit of OR space. This is me standing next to the scrub nurse. I don't know why she needed to step there, maybe to degrade me, but she's quite tall. Anyway, then we have good work economics for single surgeon surgery. This is like when we're doing cervical pedicle screws, somebody holds the drill guide, someone drills to make sure we keep the trajectory and look at the monitor, etc. And there we have it, kind of nullifying that factor. And it has enough rigidity and sturdiness needed. Although it's small dimensioned, it increases safety for placement of high-risk screws. I think we've been through all that. We've seen the literature that pediatric cases, cervical cases, we had we was very beneficial of being able to do a pediatric case with Professor Harms, who's just like 15 miles away from us. He still operates, I think, 74, 75 years old. And it integrates very well with our navigation and our image system. So it's cost-effective as well, because this system is not that expensive. And it integrates with our navigational system. We can use it for spinal, for cranial surgery, for biopsies, and ENT use it for endoscopy as well, maybe for thoracoscopy surgery. So, and then just quickly to go through the advantages of our robotic intraoperative image system. It's fast, it's an automatic registration, it has CT-like quality, up to 6 levels, depending. You know, if Shaquille O'Neal, maybe 2 levels, Danny DeVito, maybe 10 levels. So obviously, depending on the patient's anatomy. And it's a fluoroscopy, a cone beam CT, and an angiography system in one. So we don't need, like the Aero CT is excellent, no doubt, but you'll always need an extra fluoroscopy device if you're doing lateral approaches, as we mentioned before. This, we have it all in one. It has a position memory. And my favorite add-on is we don't need no extra staff. Like I was saying, lack of staff, lack of technicians, and positioning a C-arm can be, as you could say, quite challenging. I don't know if this is going to work. It should work. Sorry. Yeah, that's a shame. Anyway, positioning a C-arm is quite challenging when you see trying to park a car and you're taking about 15 moves to get this car parked in the right position for your fluoroscopy. And it's the same thing. It has position memory. So disadvantages, cost obviously is one thing, but you can nullify that by using it in different disciplines. In a hybrid OR, thoracic surgery, cardio surgery, etc. And the learning curve, I think, like I said, my first case, October 2016, using this 3D flat panel CT, I think we've done about 600 cases. And the learning curve is there. It's quick, it's efficient. The time add-on is about 12 minutes from incision to having our navigated data set. So I don't think that time factor is such an issue. So on a future outlook, the OR real estate is obviously an issue, but there's devices there, cone beam CT, as a mobile robotic device that can be driven around from OR to OR. I think the future is there. And it's a modular system where we can add on a fully robotic unit because it's passive robotic. And I think that's a speed issue. If you have a fully robotic system, it takes time to go from planned trajectory to trajectory. The robotic has to move itself. If I can move it myself with a lock and release system, I'm quicker than a robot, and then let it go and it can align to my pre-planned trajectory, and that saves your time there, and you still have the accuracy of a fully robotic system. But you're kind of faster when you move the main unit itself. So that's to conclude. And like I said, we need a rapid transition from nice to have to need to have. And I think that's the way to go to test these technologies. And that's where we have to work with the industry to tailor it to our surgical needs as clinicians. Thank you very much.
Thank you. I think it was really nice to see the workflow, step by step, how you do it. And we may disagree on some of the particular steps, but I think it's really nice to see, how you do that. And I'm a little worried about the K-wires, but I know that that's a transient problem, challenge.
Yeah.
But it was really nice. Any comments, questions, or does anybody use the Zigo? It's a Zigo, right? No,
Yeah.
Zigo.
Yeah.
Does anybody else use that for navigation? We have a system here, and we use it. We've used it a few times for spinal navigation. But you need the room. The key is that the room is set up in a certain way.
Exactly.
Yeah.
Yeah. So no questions. It's more of a demonstrational presentation.
Raj has a question here.
That was a really nice talk. I know in residency I actually use the O-arm quite a bit. And here we use the BrainLab Aero, which obviously they're mobile units. And in your opinion, with doing C1, C2, for instance, I know a lot of times we do cranial reference arrays when they're in the Mayfield. Do you feel like that's more accurate in your workflow because I heard you talking about cervical pedicle screws as well, which is not really done commonly, right?
Mm-hmm.
So the question is do you think that the cervical navigation, especially with how hypermobile the cervical spine can be, that this is more accurate than a traditional, O-arm or, like an Aero CT?
I would have to compare the data, but I wouldn't say it's more or less accurate. I think doing cervical pedicle screws comes down to where do I plant down my reference array, and plus you also have the opportunity of surface matching where you can match level for level. I can use the reference array, I can use the automatic registration, or I can use the surface referencing. And I think if you use for cervical pedicle screws, the most accurate way would be surface matching because you're matching level for level. And that kind of nullifies the mobility of the cervical spine. But otherwise, I would place it on C2 or C7, TH1, and I've never had an issue so far. Touch wood. Yeah, so.
Maybe we'll maybe Robert Eastlake in the back. Sorry. What are your thoughts about the different types of imaging technologies? The O-arm, intraoperative CT, the Zigo here. Do you have any strong opinions, one or the other?
I wouldn't say strong opinions, but the accommodation for the needs of whatever facility is getting them is paramount. If you have a small hospital, you tend to have to need instruments like this that serve different masters. If you have a place that can accommodate 3 NAV systems, you can have all the bells and whistles for each service. But I think a lot of community hospitals, outlying hospitals, need to have equipment that can serve different services needs, and they're going to be a little more concerned about the capital costs of each of these tools. So to the robot point, if you have a lower cost alternative that provides robotic assistance, I think there's going to be a valuable place for that in certain hands. So in the end, all of these things will get cheaper with time, just as all new technology does. But as we start introducing them, we'll have to be considering those things.
Now, my concern when I see these arms is always the skiving, right? I mean, the one meaning you're slipping off. You're trying to drill a hole into the pedicle, but then the surface is very corticated or is oblique or whatever, and you're slipping off, and you can't drill. I mean, the nice thing with freehand navigation is that you can kind of compensate. You first of all, you feel when you're slipping off, and then if you're slipping off, you can kind of compensate one way or the other, and then redirect to a certain extent. The challenge I have with robotic surgery or with arms is that you can't really, it takes that manual control away. Do you have any thoughts about that?
Yeah, I do. With the first cases, that's exactly what I experienced, especially in the thoracic spine or thoracic spine, because of the angulation. That's where I showed the slide where I kind of wedge it. That was my first experience. Okay, common sense. I got to take the teeth of the drill guide and wedge it into the bone, and it eliminated that factor. And the other thing is, when I showed the slide with the Tesla, I can watch the monitor while I'm drilling, and I don't have to look back and forward. And if I see a slip, I can stop and then micro adjust and rearrange, and it's okay. But it hasn't been so much of an issue, at least so far, of it slipping and scafing somewhere into dangerous territories. So.
Is Robert still here, Isaacs? No, I was going to ask him a question. Yeah.
I think the systems are getting smarter about that. They're haptic responsiveness too. So these new systems are accommodating some of those issues of skiving and adjusting in a much savvier way than we used to see them. So I think
that's a good point. The automatic module, I've tested it extensively. That also has a visual feedback if it slips from its planned trajectory, so you know in real time, okay, something's off. And you have a color visual feedback, so it kind of senses it.
Which automated?
As in the passive arm with the automatic robot module that I showed at the end. That kind of interchanges and adds on with the automatic alignment, and that reacts to slippage.
So that's the next generation that's going to turn it into a real robot?
Yeah, you add it on. So you passively move it into range of the planned trajectory, let it go, and then it aligns itself automatically in a small field. And then you, especially like for cranial surgery for biopsies, it's really, really excellent.
All right. Well, thank you. Any other questions? Or I think we'll thanks a lot.
Thank you.
So we'll move on, and we have Adrian Elmi Turander. He's a surgeon from Sweden who's published extensively on navigation and augmented reality, and he's going to talk about augmented reality navigation for pedicle screw placement. Thanks for coming over, and thanks for being part of the course. Maybe in the meantime, Ralph, do you use navigation for any of your cases?
No, I'm kind of sad when I see those pictures. But I think the reality is, at least in the European system, that money is not as loose as in the American system. The question, I used it when I was working with Harms, but the 3D was the 2006, so ESO-C 3D together with BrainLab system. The question I have is, what about all those small houses, poorer countries where the navigation is not possible? Do they lose in a certain point accuracy, or how do they position themselves? I think it's great, and when I think in my setup, I would need to go to the hospital and ask for 200, 300, 400,000 euros of investment, which is almost impossible in that time. So when I see the setup from a university clinic, even in Germany, it's amazing. On the other side, my setup is perfect for making numbers, and I'm not into a lot of high complex navigated problems. I use it more for endoscopy, and that's my normal C-arm fluoroscopy time is less than 8 seconds per case. So it's quite ongoing and fast forward.
Do you see a value in that 2D navigation?
I see a value. I think in a lot of things. First of all, 2D, 3D navigation. Second of all, augmented reality. Even when it comes more into technical details like simulation, like flight simulators, for the endoscopy, which is a technical and three-dimensional difficult field. I think it's a perfect condition. But on the other side, I think when it comes too much to investment, we have to watch out for the interventional radiologists so they don't take over that procedure.
Thanks. So we'll go ahead with your presentation. Thanks a lot.
Thank you very much, and thank you, Dr. Hartel, for inviting me to this distinguished institution to talk about augmented reality. Well, augmented reality is like Pokemon Go. These are my disclosures. What is augmented reality? Well, it is superimposing a virtual environment on a real world. In spine surgery, we project either intraoperative or preoperative radiological images and overlay them on the spine. And that is to visualize subsurface structures. How is that done? Well, it could be with a head-mounted display and semi-transparent view. It could be this Star Trek-like projection of images back onto the patient. Or you could use a monitor, like you do that with an exoscope or endoscope. And they all look very fancy. On the other hand, in reality, we are in the early stages, and the systems might not be that fancy. If we look at the history of what is published for pedicle screw placement, and here I will put together both pedicle screws, guide wires, Jamshidi needles, there isn't so much published in that field, actually. In all this publication, we talk about either clinical accuracy, according to the Gershbein scale, or technical accuracy, which is deviation in millimeters from the planned path. Wang, in 2016, published a series of 12 sacroiliac screws placed with preoperative CT and a head-mounted device with good accuracy. Our group published in 2016 47 pedicle screws we used with the video feed, and we got an 85% accuracy. Ma in 2017 used the preoperative CT and ultrasound registration intraoperatively and placed 12 needles. Once again, our group, we published our results in the minimal invasive setup and reached 89% accuracy. Gibby did a very nice work with the Microsoft HoloLens and placing 36 needles in a phantom. The very nice work from Dr. Molina that was presented yesterday also, 120 pedicle screws, and they got 94% accuracy according to Gershbein. Liebman used also a head-mounted device and preoperative CT, and Muller compared actually a conventional navigation system to the augmented reality system and found that they were as good or as bad actually, because the accuracy was somewhere more than 3 millimeters. We published the first clinical study the other year, about 256 pedicle screws placed in mostly deformity cases. And we got a technical accuracy of less than 2 millimeters and a clinical accuracy of 94%. Then we added to the same system a virtual instrument tracking mode, and we got both better both technical and clinical accuracy. And the last step, we have just submitted the paper when we added a robotic arm to the system, and we got 100% clinical accuracy and sub-millimeter technical accuracy. So the development is going fast, and the accuracy is increasing. What's the major challenges then? Okay, you want to have intraoperative imaging with high quality. You want to be able to compensate for tissue shift. Obviously, you place your retractors, you push and put in your screws, the patient moves. You need to have adequate patient tracking. And what are we using now? Nowadays, we use quite a lot of dynamic reference frames that have to be secured to the vertebra, and they can be dislodged, they can be obscured. You want to track your instruments without putting lots of bulky stuff on them. You need to have a navigation interface which is user-friendly, whether it's head-mounted device or it's a monitor. It should be something that you can use quite easily. Obviously, you want it to be accurate. On the other hand, you don't want it to take you the whole day to set up. So this is how we have solved this problem, at least. We have a hybrid OR-based system. hybrid OR-based system when we use non-invasive adhesive skin markers to track the patient. We use an intraoperative cone beam CT, and we use video cameras embedded in the C-arm for both patient and instrument tracking as well as the navigation. So in a minimally invasive setup, it might look like this. And in the clinical setup, we have a 5-step workflow. You start with positioning the patient, preparing this. This is obviously an open case, preparing and exposing the spine, placing these skin markers, and then you get a pattern. And this pattern is recognized by the system. And as far as 5 of these fiducials are visible, you can move them or you can obscure some of them. As far as 5 of them are visible, you get a good accuracy. After that, we do the CT, cone beam CT acquisition. It takes 8 seconds to perform. And with bringing in and out the arm, it takes less than 2 minutes to do the whole process. The next step, which is actually quite crucial, is the software. We get a very good 3D modeling of the spine and automatic segmentation, automatic pedicle identification, and an automatic screw suggestion. This takes 12 seconds for 5 levels. So the only thing the surgeon needs to do, and that's more or less for safety reason, is to adjust the length and the diameter of the screw, and then you're good to go. And then we use the treatment. We use the cameras to navigate. You might argue that the C-arm is in the way, and yes, it is. So in the latest version of the system, we have mounted the cameras even on the OR light. So we can take away the C-arm and have the cameras bring them into the area. And then when the screws are placed, you do your verification CT. And this gives you obviously the possibility to revise anything if anything would have been wrong despite your navigation. So what's the solution and the future? Well, this is our humble reflections. I think we are going towards intraoperative CT fused with preoperative MRI. We don't believe in intraoperative MRI because it's going to be too time consuming and too cumbersome, and you need to adapt your instruments. So I think we're going towards direct patient tracking without any dynamic reference frames, without actually any markers at all. We have done a couple of quite interesting works that we have submitted recently about tracking either skin features or spine features to replace the dynamic reference frame. You want to track your instruments, and the idea is you just take any instrument that you have, take it into the video feed, and the system recognizes that the 3D pattern, and then it's tracked without any stars or markers. The navigation interface, I think we're going to move towards the head-mounted devices, the smaller ones, especially when the new generation of my kids, the computer game players, they would like to use that, and they will be much more familiar with that than we are. I think we are going towards robot-assisted, or rather surgeon-assisted robots. That will be the future. The radiation has been addressed in several talks here. It's very important to have 0 radiation to the staff. In our study, we had 0.26 microsievert of radiation to the staff, and that was due to some mistakes. I think we can definitely reach 0. And then the workflow, as it was presented with the previous speaker here, I think that a hybrid OR or a dedicated OR will be the story of future. Thank you for your attention.
Thank you. I think this is quite challenging and provoking talk a little bit. You know, it's hard to imagine exactly how this works out in your operating room, but it's really intriguing. Claudius.
Great talk, and I agree with almost everything you said. The only question is, with the skin markers, I've talked to some people who know a lot about it, much more than I do, and they said there is a risk of accuracy with those skin markers. How did you get those 0.5, which is phenomenal, with those skin markers? Because I've heard it's not supposed to be that easy. And I mean, any movement of the skin will obviously be a potential problem. And in your system, with a perfect team like you, this most likely works. But again, if you want to have this on a broad-based use, this has to be absolutely idiot-proof. And so what are your thoughts about that, particularly the skin markers?
Yeah, I definitely agree. That has been a concern even for us, but we have actually studied that specifically. And the issue here is that you have a non-rigid point pattern recognition, which gives the system the possibility to compensate for movement of these fiducials. So we have looked at around more than 350 screws placed with this system, and in thoracic and lumbar and in the thoracolumbar junction, and the accuracy is maintained. But still, as you say, if you have a very obese patient, this might still be a problem. And that's why we are looking at developing not marker dependent, but rather feature dependent, either recognizing the whole skin of the patient, or if you do open surgery, recognizing the spine features. And I think that will probably solve that problem.
I think Dr. Isaacs had a...
You don't have fiducials on your Jamshidi?
We have actually a stripe pattern of black and white. It's two black and two white markers that we just, it's like a sticker. You just put it on the Jamshidi, nothing bulky. And that works very well.
I think you've got an amazing technology. You know, the augmented reality my concern is that you're, why don't you use like a more standard setup in terms of, spinous process clamp, iliac, what everybody else is using, is comfortable with, and just change one parameter at a time. You're changing three things at the same time. You're using skin fiducials, you're not really tracking, or you have a technology to track the instruments which people are not comfortable with. Plus you're using augmented reality. It's going to be very hard to tease those out, and they may condemn augmented reality just because they don't agree with the others. I think it was amazing. I'm not trying to be too critical. I'm just trying, from a scientific and from a comfort level perspective, why not just change one parameter at a time and use everything else the way that everybody else is doing, and just integrate augmented reality first. And once that has been integrated, then or do like parallel projects, but not change everything at the same time.
You're definitely right. On the other hand, we are at the edge of this development. Someone needs to push it, and we might have pushed it a little bit too far. On the other hand, it works. I have just a couple of weeks ago, we submitted a paper on using exactly the same technology and overlaying the augmented reality in the endoscopic view. And one of my PhD students now working on to do that in the cranial. And obviously, when we come to the cranial, for instance, then we would definitely like to skip the reference frame and be able to track other features. But it will be, with every new technology, it will obviously be like that there are conservative people that will want to stick to their fluoroscopy and do it the way they always have done it, or you adapt to the new one. And we shall see what happens. I think this is the way that the future will develop, and I hope that we can launch this system, and I hope that it will talk for itself.
Are we seeing that in the cadaver lab tomorrow, or is not here?
No, it's not here. The system is not. The system is approved for use in Europe, but it's not FDA approved yet. I think there is one system installed in Cincinnati Children's Hospital, so they are waiting for the FDA approval, and the first US system will be there in that case.
Great. I think Robert in the back, did you have?
There's technology like that out there. The skin fiducials have been an issue, for sure, but to the credit of using that kind of technology, and to some of the other comments, it's going to be a lower cost alternative to the very fancy navigation and other systems. So for places that don't have the capacity to have arrows and much more extravagant navigation systems, it'll be an easier access point. And they're getting better and better at utilizing those skin fiducials and accommodating their movement and still maintaining accuracy, probably still requiring some intraoperative verification. But I think there's going to be a place for it, for sure.
Yeah, thank you. And that's it. And we have been now working on to transfer that to the mobile C-arm. We shall see how far we can achieve with that. Just because one critic is, okay, who can afford a hybrid OR? And then intraoperatively we have possibilities to do 2 orthogonal fluoro shots and update the navigation whenever that's needed. So there are some security measures also taken.
Luke has a question or comment.
Simple question. Thank you for your nice presentation. My glimpse about your talk is just looks like the seeing the cutting one of the edge of the future. So appreciate. I have a simple question. So do you have any idea bringing the neural structure on this augmented reality field? I mean the neural structures. We're gonna see we have to find and tackle sags and traversing existing nerve root. If we have the good idea and the solution for seeing matching using the neural structure in the augmented reality is going to be very nice tool. What about your future?
We have since I know that you are interested in the endoscopic view, we have done that for endoscopic actually. Try to segment on the MRI images. We have done that for the pituitary area, the carotids and the pituitary and that area, and overlaid that as an augmented reality image on the endoscopic image, and that's working quite well in lab. We haven't reached the accuracy that we want for publishing it yet, but we are working on that. And as soon as that process is finished, the next step will obviously be to go back to spine and try to augment the spinal structures.
Rolf, any trips to Karolinska coming up for you, or?
Well, I think Sweden now has another motivation, not only the weather, it's a great tool, and I think this will be the future for people, conservative people like you, Roger, to understand the endoscopy.
All right, I'll look into that for sure. All right, I think if there are no more comments, this was really a very, very nice presentation and fascinating. And we'll hear, I mean, you have a poster here, and then we'll hear more.
Yeah, we have a poster, and Dr. Edstrom will present another study later on.
Great. All right, well, all right, thank you so much. So I'll just walk you through the rest of the morning. So we're going to have a break downstairs. Again, don't forget to visit the exhibition space. And after that, we'll have one breakout session upstairs, and that's going to be for A2L. They're going to be upstairs. It's going to be with Dr. Eastlek. He's the moderator, robotic surgery and MIS. And downstairs, and that's 10 to 10:50 with Adrian. He's going to be the moderator. It's going to be 3D navigation, augmented reality. That's M to Z. And then in the afternoon, we're going to have the same breakout sessions, but everybody's going to switch. So A2L is going to be downstairs, and M to Z is going to be upstairs. I know you take notes. Everyone's going to remember exactly what they have to do. I'll be happy to repeat it, but that's the plan. So again, the faculty, make sure you bring cases for the breakout sessions. And then after that, we'll have our Socratic battle. And so get a nice coffee, get some calories, and get ready for the breakout session and the Socratic battle.
handelt wird das System mit der Routing klein,